Hello everyone, I'm Dr. Mudit Sabharwal. I'm a senior consultant diabetologist and director at Dharma Diabetes and Metabolic Clinic. I'm the course director and faculty for fellowship in diabetes from in Iqramed Academy. As you know, treatment of diabetes is quite complex, and insulin is a major pillar of treatment for diabetes in general. And the main problem, and generally a common problem, which all of us as physicians and face, is how to initiate insulin in our patients when it is required. Now let's dig deep into it and understand how do we initiate basal insulin and what are the strategies to optimize it in general. Now let's take a case of Mr. Madan, who was visiting my OPD and had uncontrolled diabetes. Now he was 54 years old with a 10-year history of type 2 diabetes with BMI of 25. His current HbA1c was 9.3 with fasting value of 210 and ppg of 298. He also had microalbuminuria with urine microalbumin of 60 mg per deciliter. His current medication included sitagliptin and metformin 50 by 500 twice a day, glimepiride 1 mg twice a day, telmisartan 40 mg twice a day, and rosuvastatin 10 mg once a day. Now, what next is to be done for this patient? Do we increase the dose of current OHAs? Do we add another oral hypoglycemics? Should we start a basal insulin or should we start a premix insulin? I'll give you, let's say, 5 seconds to think about it. Now, let's see. What should we do? Now, in general, as per the ADA guidelines, we should be starting basal insulin to actually help the patient in general at this position, at this point of time. Why? Because we want to save the beta cells from dying out. Now, what should be the starting dose of basal insulin, and especially glargine? And is it same for all patients? Let's see. And as we know, one size does not fit all. So, of course, initiation of basal insulin is different for majorly all the patients. Now, the starting dose of insulin depends on blood glucose levels and body weight. For a 60 kg person, the initiation will be very different from someone who is 80 kgs and someone who is about 100 kgs. With the same baseline HbA1c of 8%, the initiation of basal insulin for 60 kgs would be about zero point 0.2 units per kg body weight, and at 9% it would be about 0.3 units per kg body weight to actually optimize insulin treatment. That means for a 60 kgs person, it would be about 12 units in the start, and then 18 units in the start for 8% and 9% of HbA1cs respectively. In a similar manner, in a person who is 80 kgs, the initiation would be 16 units at an HbA1c of 8% and 24 units at an HbA1c of 9%. In about 100 kgs, the initiation would be at 20 units at an HbA1c of 8% and 30 units at an HbA1c of 9%. Now, how do we generally calculate the dose? Now, optimal daily dose calculation in general is about weight in pounds divided by 2.2, which is into 2.2 is equal to units. So, in general, we say in weight in kgs into 0.2 units per kg body weight. So, that's how we initiate that. Now, what should be the starting dose of glargine in this patient? Well, his current HbA1c is 9.3, so definitely he's at uncontrolled blood glucose levels. Now, of course, the most appropriate dose for basal insulin will it be 10 units? Well, we have to think about it, and as per the protocol, should be about 18 units because his current BMI was 25. Current weight was about 60 kg, so into 0.3 units will be about 18 units at the initiation. Now, what happened after that? Now, the patient came from the first visit. We initiated 18 units of basal insulin, and at the second visit, after 3 months, the patient was still on 18 units, but his HbA1c had reduced from 9.3 to 8.3. His fasting levels were at 210, which were at 210, now reduced to 168 mg per deciliter, and 2 hours postprandial blood glucose reduced from 290 to 210. So at 3 months of follow-up of initiation of 18 units of insulin glargine, there was a good reduction in HbA1c, fasting plasma glucose, and postprandial plasma glucose. However, fasting plasma glucose was still above the target levels, which was about 168. But patient's PPG is again still not at goal. So both fasting and PPG were still not at goal. But how do we fix this? Should we add a bolus? Should we optimize it? Should we up titrate or down titrate insulin? So let's understand in the coming slide. Now, what dose titration is required in the patient to achieve glycemic goals? Although basal insulin is initiated due to irregular follow-up of visits, optimal dose titration was not achieved. The patient continued on 18 units of insulin glargine for almost 3 months, but he did not check his blood glucose even once during this period, nor did he visit his physician. Now, what is the most appropriate dose titration schedule for this patient? Let's understand that. And this is a very common problem which we see in our day-to-day practice. Patient not visiting and patient not being very compliant in general, following his treatment regularly. Now let's understand how do we tackle this problem. Now, what would be the most appropriate next step in this? Titration of glargine dose to target fasting plasma glucose at goal, adding a rapid acting insulin, or switching to BD premix or co-formulation. Now, as per the consensus recommendation for basal insulin dose, also published by Dr. Coville in JAPI in 2017, it says that initiation of 10 units of basal insulin once daily dose at bedtime can be started, can be followed. Then, of course, targeting fasting plasma glucose of less than 100 milligram per deciliter for titration. Titrating the dose up to three times a week based on fasting plasma glucose. Modifying the dose based on lowest mean value of three most recent fasting plasma glucose levels, and again reducing the dose of basal insulin by 10 to 20% if in case there is any hypoglycemia which the patient faces. Now let's see what are the strategies for optimizing optimal titration for basal insulin. Now, as per the various studies, there is a simple up and down titration algorithm for insulin glargine or any other basal insulin for that matter, which can be done on individual needs. Now we tell the patient to actually check the sugars every third day, and then we do +2 or -2 as per the units as per the requirements of the patient. Why? Because as per the protocol, his fasting plasma glucose should remain between 100 to below 100, and PPG should be less than 140. That means 5.6 to 7.8 millimole per liter. So if the fasting plasma glucose goes goes below 100, then of course, consecutively during the 3 days, then of course we tell the patient to reduce basal insulin by 2 units. And then if in case the fasting plasma glucose or the PPG is more than 140, then we tell the patient to optimize or up titrate basal insulin by 2 units. Now, of course, as I said before, so dose titration of insulin glargine was tested in numerical studies using different titration algorithms based on fasting plasma glucose to offer flexible dose adjustments to the patient and meet their insulin needs. Now, what's treat to target fasting plasma glucose? And this was published in Diabetes Care 2003. Now, this is a very simple algorithm that we start with 10 units of insulin per day at bedtime and then adjust weekly. Now, this was when the blood glucose, now patient does a self monitoring of blood glucose using a glucometer and then adjust the insulin dose in units per day basis on the average blood glucose which he is seeing during the week. Now, if the average blood glucose was fasting plasma glucose was 100 to 120, then he generally increases the insulin by 2 units. Whether if it was 120 to 140, then it's 4 units. 140 to 180, it's 6 units, and then more than 180, it's 8 units up titration in basal insulin. If depending upon the fasting plasma glucose. Now, there was another study published by Dr. Garg in Endocrine Practice 2015, which was comparing patient-led versus physician-led titration of insulin glargine. Now, this was named as Atlas study. Now, this was a multinational 24-week randomized study comparing patient-led with physician-led titration of once daily insulin glargine in Asian type 2 diabetes patients who were inadequately controlled on 2 OADs. Now, it was clearly found that there was a greater reduction of HbA1c at 24 weeks when it was patient-led titration versus physician-led titration, and there was a significant reduction in fasting plasma glucose because the patient could follow them, and compliance was also better. So the first trial, Atlantis, was basically the first trial that was comparing the two strategies. And as I said before, this basically there were two algorithms to titrate glargine insulin, which were assessed in more than 4961 type 2 diabetes patients. Now, the patient driven titration was a two-step algorithm with dose adjustment every 3 days, and physician driven titration was a four-step algorithm which was weekly titrated. Now, this was a prospective open label 24-week RCT, and the p value was less than 0.003 for difference in insulin dose, and less than 0.001 for difference in ppgs between algorithms at 24 weeks. Now, compared with the more aggressive physician-driven titration, simple patient-led driven titration showed significant improvement in HbA1c and a lower incidence of severe hypoglycemias and good patient compliance, which is our criteria and which is our main goal in general in all type 2 diabetes patients management in general. Now let's talk about patient self titration. So this was another study published by Davies in Diabetes Care 2005, Diabetes Care 2006, and 2007. These were comparing the three studies: Atlantis, which had about 4961 patients; Goal A1C, which was more than 7800 patients; and Predictive 303 study, which was again almost 7900 patients. Now, insulin was the same, so they were basically glargine and detamers, which were compared in all these categories. Titration frequency by clinician was weekly, and patient was by the patient was every 3 days. Comparing all the three studies, the hypoglycemic events, that means the blood glucose less than 70, was just 29.8% patients in clinician titration, whereas in patient-led titration it was 33.3%. In goal A1C it was 6 patient per year, and then in patient-led it was 3.7 patient years. And predictive study it was 4.95 and 6.44 in patient years respectively, clinician versus patient. Whereas in severe hypoglycemia, the clinician has 0.9%, patient had 1.1. In goal A1C, it was 0.14 in clinician and 0.09 in patient. And predictive 303 had 0.20 per patient years in clinician category and 0.26 per patient years in patient category. So as you can understand, there was almost similar kind of variation in both clinician versus patient categories, and similar kind of results which were found in both the categories. Now let's understand a simple titration algorithm, which of course will be better for us as clinician and for the patients. This was a simple titration algorithm which was again published in Diabetes Care in 2003. This was again higher percentage of patients which clearly shown that which had clearly shown that there was a higher percentage of patients that reached targets without hypoglycemias in following this algorithm. Now there were three algorithms which were compared to actually check the percentage of patients achieving the endpoint HbA1c of less than 7% and with no hypoglycemic events in general. Now, algorithm 1 had 1 unit increase in OD if the fasting plasma glucose was above the target of 100 milligram per deciliter, and this was an inside study which was patient driven titration. Algorithm 2 had 2 units of increase in every third day if the fasting plasma glucose targets were more than 100. This was also in initiate study 3, which was again patient driven titration. And this algorithm 3 was treat to target trial based, which was 2 to 8 units in increase weekly basis on 2 day mean fasting plasma glucose, and this was HCP or doctor driven study. When all three were compared, there was a higher percentage of patients reaching glycemic targets without hypoglycemia with the use of simple algorithms, the first and the second, which were patient driven itself. How do we use these titrations? So again, use of these titration in real life shows higher proportion of patients achieving their glycemic targets. Now, there was a study which was published by Hammer in Journal of Clinical Practice in 2007, where where a baseline HbA1c of 7.5%, fasting of 6.7 millimole, and 2 hours PPG 8.9 millimole were basically the targets. It was clearly, this was a 12 weeks multicentric observational study with type 2 diabetes patients, more than 6,300 patients, who were switched from premix to insulin glargine from February to December 2004. Now, patients were trained to perform SMBG correctly and accurately using a blood glucose meter. Insulin dose was titrated to target fasting plasma glucose of less than 100 milligram per deciliter or 5.5 millimole per liter, as measured by subjects via SMBG. And then mean daily insulin dose increased from 22.1 to 22.63, 26.3 plus minus 10.6 or 11.6 units at week 12. But you would be surprised to know that after 3 months of treatment, most patients achieved fasting plasma glucose of less than 120, HbA1c of less than 7.5, or postprandial blood glucose of less than 160 milligram per deciliter. Now, another study published by Riddle in Diabetes Care 2003 was on improvement of glycemic response with systematic titration schedule, and this was also called as treat to target trial. This was a 24-week RCT comparing efficacy of titration of insulin glargine versus NPH, which was added to oral therapy in type 2 diabetes. This was a small 756 patients trial, but it was clearly found that systematic titration of basal insulin, added to OAD therapy was associated with effective reduction in fasting plasma glucose and greater number of patients achieving HbA1c less than 7%. Also, another study published by Dr. Agarwal in Journal of Clinical Diagnosis in 2017, which was also on effective glycemic control with dose titration of insulin glargine in type 2 diabetes who were uncontrolled, inadequately controlled with OADs. This was also a 12-week RCT assessing efficacy of titrated dose of insulin glargine in patients with type 2 diabetes. And it was clearly found that there was an effective reduction in plasmic glycemic response in both on all HbA1c, fasting, and PPG levels with lower rate of hypoglycemias. Now, in this patient where Mr. Madan continued to follow cell titration schedule as directed by his physician, it was clearly found that basal insulin from first visit of 18 units continued till 3 months at the same level, and then at 6 months it was optimized to 24 units to meet the target HbA1cs. The HbA1c from 9.3 at the first visit reduced to 8.3 in 3 months, and then 7% in 6 months. The fasting plasma glucose from 210 reduced to 168 and then 108, and 2 hours postprandial plasma glucose from 290 at week visit reduced to 210 at 3 months, and then 130 in 6 months. So at 6 months, we were able to, and patient was able to achieve all his glycemic goals, including fasting plasma glucose, normal fasting plasma glucose, 2-hour PPG levels, and of course HbA1c of 7%, following the titration schedule. Now let's see, how does digital diabetes management help, and are there any digital strategies for insulin optimization to make our life easier? Probably. Now, this is again a study published in Diabetes Therapeutic 2017, which talks about cross-platform mobile and web-based technologies helping us to optimize insulin. Now, again, these are some simple basal insulin calculators, and where basal insulin dose is calculated using a mobile and web-based platform to automate the dose adjustments in patients who are on basal insulin. Now, these systems provide optimized and personalized suggestions for daily dose basal insulin adjustments in between patient and physician visits to actually boost patient compliance. Now, again, another cell phone based support where remote titration of glargine or any other basal insulin was feasible by using SMS messaging and phone calls between patients and physicians. A significantly greater number of patients achieved their optimal insulin dose in a median of just 3 weeks, and these were followed up by nurses who were able to contact the patient 91% of time on first or the second attempt. Now, hence, what are the key steps in basal insulin initiation and titration? So it's very simple. You have where the patient comes to you in the OPD, you have to discuss the and if the patient falls into into category of higher HbA1c, uncontrolled HbA1c of more than 8%, even if the patient is on 2 or 3 OHAs and has multiple comorbidities, discuss insulin with that patient on the day one itself, and in fact when or as and when required. And because discussing initiating insulin is the first key step to actually start the patient on insulin and win the first battle. So again, the preparation of the patient is important. Then of course you initiate the insulin following as we discussed, as per the as per his body weight. So zero point 0.2 units per kg body weight or zero point 0.3 units depending upon the starting HbA1c of 8 or 9% respectively. And then again titrate insulin accordingly. Then of course titration is, as we have discussed, is continued with ongoing educational support, especially during early initiation and titration of insulin. And of course, continuous support is very important for these patients, where continually monitoring and adjusting the therapy accordingly is uh, it actually helps. So, as per the various studies, optimized titration of insulin leads to effective glycemic control. So, insulin dose titration is very important to achieve glycemic goals. Dose titration is patient specific and should be done in order to achieve target fasting plasma glucose and HbA1c. And of course, adequate titration of insulin dose, either by physicians or by patients themselves, can help patients reach treatment goals, including HbA1c of less than 7% and fasting plasma glucose of less than 100 milligram per deciliter. The choice of between algorithms may depend on clinical circumstances and the patient willingness and ability to become more involved in the management of therapy. So, of course, in our patient here, the early initiation and optimization of insulin glargine in this particular patient who was inadequately controlled on glycemic levels with 2 OADs led to reduction in his fasting and plasma glucose levels, reduction in his HbA1c levels, greater treatment satisfaction and patient compliance, and of course, improved quality of life, which is the most important part for our for the current diabetes management. So, of course, the evidence from treat to target trials suggests that optimal dose titration of insulin glargine targeting fasting plasma glucose of less than 100 milligram per deciliter results in a greater HbA1c levels reduction with reduced number of hypoglycemic events. So, the key message for today's class is very simple. Basal insulin dose initiation and titration is very important to achieve the target glycemic goals wherever it is required. Dose titration is patient specific and should be done to achieve fasting target glucose. Insulin dose titration offers flexible dose adjustments specific to patients' requirements, and compared to conventional intensified approach, insulin dose titration offered a greater patient satisfaction and a good quality of life for them.